Hey, this is Dr. Livingston, and here is our lecture on the theory and practice of family therapy. First of all, I want to start off with just kind of talking about family theories in general, um, and then we'll kind of get off into the actual practice theories. So, this is just on family frameworks, so to speak. So, when we're talking about a family relationship framework, this is one of the things that we have to understand first before we start working with a family. So, the family itself is a microculture. It has its own uh, social construct, social norms, social expectations, all of the above. So, within a family setting, within that microculture, we're going to see an evolved set of rules. So, this may mean that over time, we can see that evolution of rules as to who does what in the family. Um, that can also mean that they're a highly structured set of rules. And when we're talking about rules, this is just more of how the family functions. Um, and we'll kind of get into describing that a little bit more here in a minute. Within each of the family members, we're also going to see different assigned and ascribed roles for each of those family members. Um, we're going to see that organized power structure, who's in charge, who makes all the decisions, who, if there is one, who undermines that power structure, who challenges it. We're going to see the intricate, overt and covert forms of communication, and these can be very deep-seated and typically nonverbal. Um, Again, we'll kind of get a little bit more into that here in a minute. We're also going to see that each family has their own ways of negotiating and problem solving. Um, we might see some families that, excuse me, that engage in arguments, or might get very loud and sound aggressive, but actually are that's a way of their communication. There's no negative emotions attached to that. We might see other people that or other families that um, want to actually sit and calmly and rationally talk about the situation and have input from each family member and things like that. Um, and sometimes we might see ways of negotiating and problem solving that involve undermining others or more passive aggressive or manipulative tactics. So all of these still play that role or that part in uh, that system, that microculture system of family. Um, we have to understand that the relationships within a family are very deep. And of course, we understand this. We all come from families. We get that. If we think about our own families and apply these ideas to our own, it becomes very obvious, what these points are. So the ways that family relationships are so ingrained is one from the shared family history. Um, that's what gives the basis for a person's understanding of the world, essentially. And that kind of goes into that next bullet there, that we develop these perceptions and assumptions about the world um, through our family stories, from our family history, from what is passed down generationally, or what we witness in our family. So that creates whether we view the world one way or the other. Um, those relationships also provide a sense of purpose. Um, the family structure itself provides that sense of purpose, and what a person's individual role within the family is also lends to that. So family therapy ethics, we've actually kind of covered a lot of these things in previous lectures when we talked about insurance, malpractice, um, and then also within, individual therapy. So the first thing that we need to just really take in and make sure that we do this is recognizing when we are in over our heads, especially with a family. There's that it becomes very, very complex. Individual therapy, yeah, we can probably handle that to a certain point, and but actually be able to get pretty far before having to refer out. Usually, it's going to be issues of acute trauma or when you get too deep into past traumas. But when we're working with a family, that can happen really, really, really quick because the dynamics of a family are, well, just like I said, I mean, I can't say it, I can't say it any differently. They are just extremely complex. So don't hesitate to refer out to someone that is more qualified. Because if you don't, um, and you don't have special education, training, certification, experience, something, uh, in specifically in family therapy, then you could find yourself facing some lawsuits for some of these reasons. So financial liability, we have kind of talked about a lot of these topics here. Do just kind of want to review a couple of them. So intentional versus unintentional harm, of course, I think we can kind of get what that means. Um, what we do need to understand about this one, though, is that with unintentional harm, that comes from being in over your head. So again, refer out. Let's see, we've talked about breach of confidentiality before. Obviously, sexual misconduct, not okay. Uh, Negligence, breach of contract. Now, we do have two new situations here that could lead to some financial liability. Failure to protect, that's going to come into play with being mandatory reporters. Um, and the dynamics of that within family therapy become um, difficult, to say the least. And so if we know something is going on, we don't, we're mandatory reporters. If we don't report, we can actually find ourselves being charged with failure to protect if, an abusive situation is going on or neglectful. Then we also have exercising undue influence. Again, I think you guys can probably figure out what that means, but when we're working with a family, um, sometimes we can inadvertently even, which would kind of fall under that unintentional harm, um, we can inadvertently, overly influence a particular family member, or, take sides, or, all of these types of things. So it's very complex. Personally, I don't do family therapy, because of a lot of these reasons. Um, Now, moving on to malpractice. Now, these are going to be pretty much all of the same malpractice standards and risks as with individual therapy. The Really the one that I want to talk about is the confidentiality within, if you're doing if you're doing couples therapy or family therapy. So basically, you have to treat every single family member as if they are your individual patient. Um, Now, obviously, if you're talking to them as a group, that does not apply. But you have the family as a patient, so the entire family has that circle of confidentiality. Then each individual member also has confidentiality. So, it just, again, there's just more layers. It just becomes more complex. Um, the way that I kind of approach it is obviously I explained that at the very beginning if I'm doing couples therapy, which is very rare. But sometimes I might be seeing, a parent and a child, or maybe I'm seeing, two parents, but I'm seeing them for med management, and it's gonna the same thing is gonna apply. Um, if one of them says, "Oh, I'm sure they told you about this," or "I'm sure they told you what happened," My response is because that's a very benign way um, that they might not be recognizing that that would be a breach um, or a violation of confidentiality. But the way that I respond to it is I just say, well, I can't tell you what they have or haven't told me, so let's just pretend I don't know anything and you tell me what you think I need to know. And I usually don't have any other issues. Um, on top of that, that strengthens the therapeutic relationship. When you're seeing, even if you're not doing a entire family as a, family unit for therapy, some of these um, some of these situations can also apply to just seeing individually multiple members of a family. Now, granted, for individual therapy, we probably wouldn't do that quite so much, but certainly for med management. So some of that stuff would still apply. Getting back to talking about that family narrative, that family story, a little bit more in detail. So families create their own meaning and their own judgments about what reality is through their beliefs and their stories. Um, an example of this might be, and I always kind of think about more of the extremes, but uh, you know, stereotypical, country family, if you will. um, they might not go to not go to the doctor because every time somebody goes to the doctor, they die. This is a very, very common thing for some of our older generations, and so that sometimes gets passed down, and people get very hesitant about seeking out medical care. And the reason that they seek out or they get hesitant about that is because what they've seen is that once someone starts going into the hospital, they start going to the doctor, there's something wrong. And so the belief, the reality starts to form around this idea that it's actually going to the doctor that's making them sick. They're just looking for stuff. They're just finding stuff. They were fine until they put them on that pill. Everything was fine until you started going and talking to that head doctor. I've definitely heard myself be called that. um, and so, there's this ideology that starts to form about what their reality is. Um, not trusting law enforcement. I know there's a variety of different groups that kind of feel that way right now, but uh, there are some that under no circumstances would you dare call the law. We're going to handle this. We're going to handle this between us, um, because the law doesn't need to get involved. Because when they do, things go wrong. And so now we've got this perpetuating idea that having having any type of the judicial system involved at all is going to be bad for the family. It's going to end up, bad for the family members. Um, this also, however, goes into or goes back to, I guess, um, uh, touches on our attachment uh, styles. So if you look down there, we see reality is a perception created by the family. Um, Now, think back to when we were talking about attachment theory and our attachment styles. So when we're talking about that secure attachment, um, the outcome of developing a secure attachment is that the worldview is that it is safe, it is orderly, it is predictable. Um, for someone with disorganized attachment and coming from the family that creates that, they might develop that unstable, chaotic, and dangerous worldview. And so that then becomes the reality. Um, Within, and I just kind of wanted to throw this in here just because I think it's important to think about some of the philosophical viewpoints, especially when we're talking about mental health care and therapy, and especially within family therapy. So we've got this postmodernism philosophy that there is no true reality, um, and within that there is no absolute truth. My truth is my truth. Your truth is your truth. Um, Now, this is to not be mistaken for fact. Truth is not fact when we're talking about philosophical things. Um, so when we're when we're trying to understand a family that is maybe different than ours, that is, going through problems that, uh, you know, are maybe based on this skewed worldview, we have to understand that their reality is what is true for them. And so we have to build on that. Because you're not going to be able to do anybody any good if you challenge uh, their if you challenge their entire family history, essentially. Now, some people are ready for their family history to be challenged, and that's perfectly fine. If you get lucky enough to have one of those patients, great, you're going to get far. But most of the time, even with those folks, there's going to be something. There's going to be something that's going to be challenged. Um, explaining, sometimes explaining to people. Okay, here's an example. Take my mother, for example. Um, we got into a discussion, this is some years ago, um, about use of corporal punishment, spanking. And I got spanked, I got paddled. I probably at some points, uh, even in even for the time I was being raised, might have crossed that line into harsh punishment, into abuse. But it was never considered abuse. But that doesn't necessarily mean that it wasn't abuse, because when we look at or at least maltreatment, when we look at that as the definition now, it's like, well, it's a traumatic thing to tell a 6-year-old, my grandmother or my paternal grandmother did this one, and I'm sure if you were raised in the South, you have done it. To go outside and pick a switch, that's traumatic. You are going to pick up the weapon you're about to be smacked with, and it's going to hurt, and that's the point. Um, but that was punishment. That wasn't abuse. The reality, the trueness for my family was that that was not abuse, even if you applied it to today's standards. So that's what we have to understand when we're dealing with these types of families that are struggling with this, um, and just kind of build on that. Uh, One thing that comes to mind just as a actual uh, therapy example, worked with this family that and this is out kind of more in rural areas, and we're spanking with a belt and spanking with a switch and all that sort of stuff is still very much so socially acceptable, um, and trying to get parents who are raised that it was socially acceptable, who believe that it was socially acceptable, who maybe even see a benefit in it, to stop doing it is extremely difficult because you're challenging their reality. And so in those situations, what I would have to do is say, well, I understand, that's how I was raised too. I get it, but I'm just telling you there are some better ways to get the same results. And you don't have to, exert the energy of chasing them down and spanking them. So, and we made some progress. Just take some time. Other aspects of the family that we need to take into consideration is the family resiliency. And again, going back to uh, when we're talking about trauma and resiliency, it's basically the same application, just on a bigger scale. Um, for example, when a prominent family member gets sick and they can no longer fulfill their role, is the family able to bounce back? Is the family able to uh, take over the role that the sick family member, or the duties of that role, and so that the family doesn't fall apart, so that the family continues to function the way that it always has. Um, that's what we talk about with family resiliency. Um, Within cultural diversity, we want to remember that, culturally speaking, um, we have a lot of different definitions of what is family and what the roles for each of those family members are, and what the expected patterns of interactions are going to be. Um, in a lot of, American, I guess yeah, I'll just say just, stereotypical American families. When we define family, we're thinking of, mom, dad, or parents, um, children, maybe now, aunts and uncles, and maybe grandparents. Um, in Southern families, it's parents, children, cousins, aunts, uncles, grandparents, married in family, extended family. Families families become very large here in the South. Um, in Kind of stretching that a little further, and I think we're seeing this more in a lot of Southern families, but in a lot of Black families in the South. Um, we see that close friends of the family, um, people in the community that are important to the family become family members. And so, that's something that we have to take that into consideration. Um, when we think about going even bigger than that, a lot of Asian families, Chinese, for example, and Japanese too, also, their family also extends to ancestors that are still an active play an active role in the family because of the honor that needs to be held to them. Um, so there's all these different ways that the different families from different cultures define family. Now, when we talk about family roles, um, there's I think for the most part, here in America, we're seeing a lot of less stringent lines or boundaries on family member roles, but we still have some pretty good examples. So, in some families, it is acceptable, and this might not necessarily be a role, it's more of a pattern, but it might be acceptable for children to argue, talk back, perfectly fine, um, as long as it doesn't cross a line. Sometimes lines are crossed. Sometimes there are no lines. But in some other families, um, not responding with a yes, ma'am, yes, sir uh, response is considered arguing. Um, so there's those patterns we need to pay attention to. With family roles, getting back to that, um, I think that we probably see it more, probably awfully, often see it more in the South again, where we have those more strict uh, roles for mother, father, sibling, oldest sibling, youngest sibling. Um, who, what do they do in the family? What is expected of them? Um, and that changes, culturally as well. So now moving on to gender roles, this becomes even more evident in, well, we have just pockets all over the United States. We definitely see it a lot more in some other cultures, um, but just generally speaking, um, many of us were raised with the ideas of girls wear pink, boys wear blue, girls do gymnastics and ballet, boys play sports, um, girls play dolls, boys play in the dirt. These expectations, right? So that's what we get raised on. Well, then when we start talking about more of the ideology behind those gender roles, That's when we can start getting people who feel inadequate when they can't measure up to the expectations of the roles within that ideology that was imparted to them through their family. So I always think about I, and this is definitely kind of dying away, which is kind of nice, honestly. But good example is, a man makes the money and takes care of the family, and you're not a man if you can't do those things. Um, and so if that is how your self-worth within your gender, being a man, was ingrained, and let's say then that that man can't work for whatever reason, or let's say wife gets an amazing job and is making more than him, we might have some issues. Not necessarily, well, eventually might, if you can't overcome that. But we're going to have some issues in those interactions because he's going to be struggling with that that ideology of what makes him a man. So all of these things we have to really kind of pay attention to when we're working with families. Now, specifically talking about the impact of gender and culture in therapy, there's a couple of things that we got to think about as therapists. One, how has gender or how have gender influences or influenced, there should be influenced, your personal development? What do you hold as your beliefs and your opinions about gender roles, about the ideology of gender? Um, what are your opinions about gender and sexuality? Um, Working with LGBTQ plus families and individuals is becoming more and more common. We're which is great because that means that we're making a safe place for those folks to be able to come into treatment and feel safe to come into treatment. Um, but if that's something that you haven't really explored what your opinions are, how do how you feel about that, then how are you going to be able to help someone work through the challenges of coming from a family where the gender role that maybe they're trans and that is not okay in their family, um, and you haven't figured out exactly how you feel about that, you might not be able to help them through that very well. You might do unintentional harm when you're working with same-sex couples that are raising children. Um, there's always a possibility for, inadvertently um, not being able to really understand the experience of that family, um, or maybe having misconceptions about the experience of that family. Um, we also have to think about the potential biases that patients may have. This is kind of a big one, actually, um, because if if someone believes um, that uh, be it male or female, is a better uh, better therapist for them, um, and you happen to be the opposite, then they may be hesitant to accept that. Um, if you are lucky enough to have some of those wonderful patients that believe that women are not as smart as men, that women cannot be uh, quote unquote doctors and prescribe medications, that women can't necessarily be that level of professional. Um, you're going to have some challenges, um, and you're going to have to think about, well, how are you going to handle those things? If you are of a different race or a different culture or different ethnicity or just a different part of the world, just in general, a different part of the state even, um, from your patient, um, how are they going to accept that? Um, there's a lot of people that are from, and this is again, we're working on stereotypes because that's a lot of times what tends to create these biases. But um, there's a lot of people from a lot of other parts of the United States and then also around the world that view us Southerners as more ignorant um, than the rest of the world. And whereas, we got our own special way of doing things, that doesn't mean that we're any less intelligent. But if you have someone that um, that feels that way, um, and I know every once in a while my Southern accent comes out thick, super thick, then that might be problematic. And then, of course, your own biases. Um, you know, uh, are you always going to lean more towards, the side quote of the person that shares your same gender? Are you going to lean towards the side of the person that's the other gender? Are you going to uh, maybe even subconsciously hold on to cultural biases? Um, so these are all things that we have to explore when we're trying to do therapy with families or well and also individuals because we have to understand this too.
Looking at the family life cycle, there are these seven you know, stage markers, family stage markers. And what we need to understand about each one of these is that each demands some level of change and adapting to new a new definition of how the family is functioning, what the family is. Um, what are the priorities in the family now? But if families are unable to adapt to that, then that's going to trigger dysfunction. So at each one of these, we have the unfortunate opportunity for dysfunction to take place within a family unit. Sometimes we just have to help families from one stage to the next, maybe in that finding adaptation. I know a lot of families really struggle when children become teenagers, and teenagers are wanting more independence, and parents aren't quite ready to give it yet. That is a very, very common situation, and so some of those situations we could definitely handle without having to refer to specialists, because those are very um, normal situations. Now, again, if you don't have the experience, refer out. Um, can't stress that enough anytime I bring it up. So, anyhow, so we have all of these different stages, and then we have they weren't necessarily identified as part of those family stage markers, but we have that special situation or special situations that come from divorce. We can have single parent homes. There's a lot of adaptation that has to happen. Um, Couples that are now separated, learning how to co-parent. Um, that can be very, very difficult. A lot of times after divorce, when we have a dysfunctional co-parenting or joint parenting situation, kids are the ones that struggle. We start seeing a lot of behavioral issues. Um, so again, that's another stage. And then of course remarriage. So being aware of all of these, recognizing what is quote unquote normal or typical within these stages, to occur because we do have to allow for some level of adaptation, on its own. Things settle. Um, but then recognizing when, okay, yep, it's gone past the point that we should have found our, the family should have found its own way. Now we might need to, yeah, they could use some assistance. So when we're doing family therapy, there are some gender considerations that we have to take. So first of all, we have to understand and just accept that the family that we are working with, they are who define the gender roles within their own family. Um, that is, it is not our job to do it. And we just have to accept how they do that. Now, if they need help in defining those, if they maybe don't know how to define them and just need some assistance in that, um, we can certainly assist them with that. But we are not actually providing those definitions. We're not telling them, you know, who fulfills what gender role, and what that means. Now, when we're talking about feminism in therapy, this is where we need to, if we're coming from, a feminist base, this is where we want to identify the areas where there is reinforcement within the family of traditional gender roles. Now, we also, of course, have to understand that the family also gets to kind of define this and whether they want to continue with that reinforcement or if they want to change that. Um, Now, the gender roles that are identified um, would be, you know, feminine dependency, nurturing, emotional expressiveness, and then male aggressive competitiveness and rationality. Um, so that's just kind of those are the areas that feminism comes out in that. Now, when we talk about gender sensitive therapy, what this means is that we are emphasizing gender equality and kind of stabilizing the power hierarchies within the family. Um, the overall goal is just to kind of help family members understand those stereotypes, um, and that, you know, basically those are social constructs. And regardless of gender, we have, or they have rather, the ability to, I guess, kind of accept their responsibilities within their gender role, in more positive ways, rather than looking at it as being, limiting. Um, and there's a lot of different aspects to gender sensitive therapy, but it is very action oriented. We're going to challenge those gender stereotypes. We're going to promote positive power dynamics. Um, we're also going to address gender differences. So, there really is a lot of involvement from us as a therapist in leading those actions, leading those conversations. And then, of course, we have to always consider just in general any of our LGBTQ plus families, because not only are they struggling with just the day-to-day life of being a family, um, with kids and responsibilities and all of the stressors of just that, but unfortunately, they also have a lot of stress coming in from, um, the outside world. And sometimes children of, LGBTQ parents, or if we have, a child that is, within that community, then that brings on a whole lot of other struggles for that family. It brings on a lot of anxiety and fear and things like that, that you could, with any caring family, that would be, that would be pretty reasonable. Um, Sometimes we actually might even have to assist families in understanding another family member that might be within that community. So it can, there's quite a variation in how family therapy is utilized within these specific contexts as well.
Quickly, history of family therapy. So, family therapy actually kind of sparked a big interest back in the 40s and 50s after uh, men were returning from World War II. And they've been, our whole nation here was kind of uh, very much so uh, kind of turned on its head um, because of that war, with how families were restructured, and women in the workforce, and all of these types of things. And then we have men returning from war with uh, you know basically PTSD, and loss of functional abilities, physically speaking, all of these, all of just it was so much change that happened. And so, therapists at the time were seeing this influx of families, basically families coming in saying, we don't know how to function anymore. Um, so in walks family therapy, and really trying to figure out why and how the family unit as a whole contributes to psychological uh, upset and disturbance, as I put there. Um, and I'm just going to throw out here the the schizophrenic, what is it? Schizoprenogenic mother. It's not the easiest word to say. So, and this was a woman who proposed this. 1948. She had worked a lot with schizophrenics. That was kind of her specialty. And from Reichman, that is. And she started to, with kind of the new focus, excuse me, new focus on family functioning. Um, she started looking at the family in a different light, and kind of felt that she was seeing a pattern of behaviors uh, from the mother that would that she thought caused schizophrenia, basically. So what we'd see is that the mother would have qualities of domineering, cold, rejecting, possessive, guilt producing, and then father would be passive, detached, and ineffectual. Now, if we look at her timing here, what she was probably seeing was father's coming back from the war. They don't have a job. Um, they have not been in control of the household for, however long they've been gone. Um, they are psychologically damaged from war, and are trying to reacclimate to even being present. On the other side, we've got women who were essentially single mothers who had to take charge of things that they had not been brought up to know how to take charge of. Women didn't. That wasn't the way. That wasn't the way. And so I'm sure that there was probably a um, a great deal of resentment, animosity, um, uh, along with this inability of not knowing how to manage the level of authority that women had to have at the time. Um, and so then, and this was only applied to men, by the way, only male children, only sons. Um, the son is then confused and feels inadequate because of how he was treated by his mother, and father not being a role model. And that then causes the development of schizophrenia. Of course, that we know that this isn't true, but it is just it's a very good example of how the dynamics of a family um, can be taken out of context for a particular culture or a time frame, um, and given more meaning than what is really there. Now, I will say that it's kind of interesting that uh, if you switch mother and father on that one, you have a very typical combination for development of borderline personality.
All right, so here it is. This is the list, and this is not, I don't believe this is an all-inclusive list either. But this is a list of the most common um, family therapy models. We're not gonna we're not gonna talk about every single one of these, but we are gonna touch on a few. Some of them will go a little bit more in depth, others a brief overview. So psychodynamic models, of course, these are theories that originate from Freud's psychoanalysis. So we're going to have a lot of subconscious themes. We're going to be really looking at that subconscious and unconscious mind as kind of being the source of any of the problems that someone might experience. Um, the The other things that we're going to be looking at within these models is the motivation that someone has behind their behaviors. Um, and that kind of goes along with the instincts and drives. So an instinct is something that is needed for survival, something that we can go out and get and satisfy that need. It's going to be stuff like thirst, hunger, avoidance of pain. Um, and our drives are our desires. They're the things that we can't really satisfy, but they provide the stressful internal motivation um, on the consciousness. Um, now we have four different components of each of those drives. Um, our impetus, which is the pressure. That's, obviously how forceful, how much of a level of desire, anxiety, motivation um, does this drive produce? Then obviously our aim. Um, what are we seeking out, right? Our object. What's what's going to provide it? And then our source. Why? Why do we need it? Where's it? What's the somatic manifestation um, that is coming out in psychological ways? So there's a lot to that. That was the most simplified I could possibly get those. Um, if you want to know more about those, let me know. I will be more than happy to talk to you more about them. So we've got four primary psychodynamic models. First, we're going to be looking at, or first up rather, is object relations. Now this is going to combine. Well, I don't really want to read all of this to you. So our object relations is basically we're looking at how does how does a person um, interact with another person based on their understanding that that person also has a separate experience from them or from theirs. This is kind of rooted in the child mother or mother figure attachment. Um, so we can look back at some of those attachment theories that kind of go along with object relations. With self psychology, we're going to be looking at how a person, basically how a person views, perceives, and interacts with um, outside objects. Now remember, objects we're talking about, these are anything that we have a relationship with. Um, Now with self-psychology, we're basing this on the assumption that in infancy, we view the parent narcissistically, meaning that they are there to satisfy our needs, right? They are a self object, they are an extension of ourselves. Now we have to kind of work with that and work from that base, because the idea is that the progression into being able to identify another, an outside object as another that also has perception and experience is kind of what we're working with there. Is moving on to intersubjective psychoanalysis. This is coming from a base that every interaction that we have takes place on this intersubjective field, which means that there is no one experience. Um, we can be in the same room, and you can have 10 people in the same room, and all 10 people are going to have a different experience, but all of those experiences take place on this intersubjective field. Um, the idea here is that we are also recognizing that other people are experiencing things from a different perspective. So we are kind of utilizing the concepts of reciprocity and some of those organizing principles within uh, experience and perception. In relational psychoanalysis, um, this is something that is also going to take place on that intersubjective field, but I guess basically the underlying idea here is that the relationship itself between therapist and patient is the healing relationship, um, and so there's a lot of leveling of that relationship. So let's go a little bit more in depth into some of these. So this is the classic psychoanalytic theory. This is the Freudian-based model. We've already talked about those biologically determined forces, or those and drives and instincts, and then those components of each drive. Not going to review that again. Go back a couple of slides. Um, so again, with our classic psychoanalytic theory, we are going to use this therapeutic application of the concepts of transference, countertransference, and then resistance and interpretations. So let's talk a little bit about those two concepts, because we haven't really talked too much about those yet. So with resistance, this is when a patient is just resistant to exploring transference, or maybe the source of the transference. Maybe they can identify it. They're like, okay, yeah, we could talk about it, but I don't really want to talk about where this is coming from or why I'm doing it. Usually this is some sort of unconscious block, um, and we tend to see some of the defense mechanisms and things like that coming out. Um, but it is something that is kind of part of psychoanalytic theory, so we do have to utilize that. We do have to use that concept of resistance, um, and then we're also going to use interpretation to interpret that resistance, and then also interpret that transference. So if we, have a family that is, or a family member even, that is just for whatever reason resistant, um, we have to be able to explore that. Some of the things that we're going to utilize within this model or within this theory is challenging interventions. Now, this is not necessarily to say that we're going to challenge our patients, but basically that we're just not really going to take what they say at face value. We're going to read into those nonverbal cues. We're going to challenge the differences between what they say um, and what is recognized. So, a good example of this, I have I have a patient that I've seen for a long time, and she thinks she is great at hiding her emotion from me when she comes into the office, and she is not. She can walk in and um, have, a big smile on her face and come across as, in a very jovial mood. And as soon as I say, "Hey, how you doing today?" "Oh, I'm fine." Mm-mm. Nope, I can see it in your face. You're not fine. What's going on? That's what I mean by, or what is meant by challenging interventions. We're also going to be identifying defense mechanisms. So, defense mechanisms are used by our ego, which of course our unconscious self is made up of our id, ego, and superego. Um, but defense mechanisms are used by our ego to kind of decrease the stress that is occurring between the id and superego. Um, Now there's quite a few of these. I'll just kind of read you off a little list here. We've got repression, reaction formation, projection, regression, sublimation, also known as deflection, denial, rationalization, displacement, introjection, which is kind of adopting the opinions, thoughts, or maybe even personality traits of someone else. Um, and intellectualization. Um, yeah, I'll briefly go over the unconscious self. So, just as a brief little review. So, the id is our unconscious, primitive, impulsive, demanding, chaotic, and unreasonable self. Um, it wants what it wants, and it wants it now. Um, this includes libido and aggression. Um, these are also or can also be called eros, which is the life instinct, um, and thanatos for aggression. Just some little tidbits. For our ego, that is our rational conscious mind. This is the reality principle. It is the mediator between the id and the superego. The superego then is the um, morality principle. It is we do what we were supposed to do. We follow the standards, we follow the codes. Um, and a lot of times what the id wants does not follow those standards and codes. So ego gets stuck in there in the middle, and that's where our conscious mind is having to deal with the manifestations of our unconscious mind.
So again, kind of like what I was just talking about. We've got these object relations that or the interpretation, the internalization of past relationships, past objects that we then apply to current ones. Um, and that's something that Fairbairn always, it's just a interesting name to say. Anyway, something that they kind of contributed to this uh, idea of object relations is splitting. Now, if we if we take a really big grand step back, we can see a lot of the basis of development of borderline personality in object relations theory. And within this relationship to mother or primary caregiver. So when we're talking about splitting, so what happens, they say, is that when there is a conflicting views of, we'll say mother. Um, Again, that doesn't necessarily have to be a mother, but the one who fills that role. So when we have this conflicting view of mother, where we have this going back to attachment, we'll say that development of that the anxious avoidant, um, where sometimes mother is nurturing, sometimes mother is frustrating or harmful, and the the child is unable to really reconcile those two, and so what they do is they accept mother as both, but then when they then shift that transference to someone else, um, then we start to see that we have an all good or an all bad. So we have that black and white. Um, that's where we start. That's where we think about that uh, some of those very core symptoms of or characteristics, I guess, of relationships within borderline personality. We do see that we have all good or all bad, and so that's kind of that basis for that. Um, Now, of course, sometimes kids aren't able to do that, or they're not able to kind of manage that view of mother as both. Um, and then that's when we really see a lot of attachment and relation uh, difficulties. Okay, so let's talk about these different uh, environments. So we've got our holding environment. Holding environment is that safe and nurturing environment that mother creates, and that then allows for healthy attachment, secure attachment, uh, development of self, and the that safe worldview. Um, Shared holding um, is when we as therapists kind of create that holding environment. um, so that our patients can grow and heal. Um, and that actually is very important, because it's um, people who have not been raised in environments that they can feel safe, to share their thoughts, feelings, and emotions. Um, they need that safe environment. And so as therapists, we need to be providing that for them. And it does help to heal. Um, Another, and this isn't necessarily part of the environments, another is family of origin and how it relates to uh, marital relationships. Um, so family of origin theory is basically saying that it's a combination of psychodynamic and family systems. So what it's saying is that holding on to that psychodynamic approach within object relations and how um, uh, past relationships can then be transferred onto current relationships, especially within a partnership. It doesn't necessarily have to be marital, um, but at the same time, we're also taking into consideration the entire social family systems aspect of where that person came from. So bringing those two together to really work to provide that family therapy with regards to that. And I do like that blend, quite honestly, because it's taking into consideration the person's individual um, experience and psychological basis, in their internalized everything, but it's not leaving out the uh, that family system uh, microculture that they came from. So, okay, so this is kind of an interesting one. So self-psychotherapy, this is very much so based on working with narcissistic personality disorders. So let's kind of think from that hat to understand this. So um, basically, we're saying that, or in this theory, we're saying that all of this starts in infancy, of course, and we have self objects. And so what happens, or what's supposed to happen, is in infancy. Um, Children learn that they themselves are an object of someone else. Um, and then that gives them, when they develop that, um, it allows them to understand that their needs can be met by an object and they can meet someone else's needs. Okay. Now, what happens though is that transition doesn't happen. Um, People with narcissistic personality disorder don't transition into recognizing that um, other people exist and have their own needs and wants. Kind of thinking back to that for a minute, right? Um, so they they never develop that um, they never develop that understanding that another person exists in their own world and has their own reality. They continue to view everything as their own. And that's what mirroring is recognizing that um, that another person is not just simply a reflection of me, that you have your own life, your own experiences, um, your own self. Bear with me. So, intersubjective psychoanalysis. So, what we're saying here is that every interaction that we have takes place on what's called the intersubjective field. And the intersubjective field is saying that my subjective self and the patient's subjective self, or whoever's subjective self, are coming together in a um, shared experience. Um, and our interactions are reciprocal. But we're understanding that your your subjective experience is going to be different than my subjective experience. Um, but we are agreeing upon certain mm, certain rules, that certain patterns of interaction, um, that establish those organizing principles so that we can interact um, in a way that actually means something, or in a meaningful way. Oh, that's a better word. We can interact in a meaningful way. This is, I mean, it's kind of almost exactly what it sounds. Um, what we're doing here is we are um, assessing, I don't want to use the same word, we are identifying how um, outside influences, whether that be uh, relationships, experiences, um, happenings, events, all of that, um, in cooperation with a patient's, whether it is the inner worlds or our psyche, in developing our interpersonalists. Um, this is also going to occur on that intersubjective field. Um, there's the way that this works is within this one we're going to do basically it's just going to be a two-person thing. It's just going to be the patient and therapist. So we're not going to necessarily have um, family in here. Um, the the basis here is that the therapist is no different than the patient. They are equals. They participate equally. Um, and the there's communication, there's discussion, there's back and forth. Um, and quite honestly, this is it goes to or it fits a lot into kind of a core part of my approach. I'm very, very eclectic. Um, but it's very helpful because it takes away any of the anxiety that a patient might experience because of the perceived hierarchy. Um, and so it helps. It helps in building that relationship. And so the whole goal here of this one is actually developing the relationship. and the relationship with that the therapist has with the patient. Um, there's a lot of self-disclosure, and there's a fairly healthy rejection of countertransference and the inappropriateness of countertransference. It's actually used. It's and this is something that I don't ascribe to, but um, it's the building, like I said, it's the building of that mutual relationship that that is the helpful thing. That's the healing thing. And so we're actually uh, embracing the transference and countertransference that happens there, and mutually breaking that down and assessing, and all of that, so that we're coming to a different understanding of the self in both selves, therapist and patient. Um, Blank screen approach, full rejection of that. So blank screen is where, that it's kind of that the previous approach of psychodynamic was, we all think about those old pictures, those old like drawings and stuff, posters. I always think about it. I've got one in my office, and it's just the patient laying on the couch and the therapist sitting there, and it's just mm-hmm. And how does that make you feel? Where there's no real interaction, no real personal interaction from the therapist. So this is rejection of that.
We've got a couple of transgenerational models. Bowen Family Systems, this is the one that we're really going to look at within this model or within this type of models. Um, it is the probably the most well known. And then but we also have contextual model. Now this one is very heavily influenced by object relations theory, existentialism, and also interpersonal psychiatry. It kind of takes all of those, blends them together, and adds a little bit of this ethical perspective in looking at how the balance within families is maintained, and then therefore how it becomes skewed. Um, this uses concepts such as the family ledger, um, and also introduces the concept of family legacy. Again, we're not really going to get into this specific type of therapy. Um, so if you are interested in learning more about that one, definitely let me know. We are, however, going to be talking about Bowen. So let's get over to that one.
When we're actually doing therapy from a Bowen systems model. So the therapist definitely has to remain objective. Not You can't get emotionally involved, because if you become emotionally involved, then you may very easily be triangulated um, in that situation. Um, because everybody, I mean, when we're dealing with a dysfunctional family, everyone, and well, just anyone, honestly, um, people want you to take their side. That's a given. They want you to take their side. And so when we're dealing with a dysfunctional family, we're going to have more efforts that are going to be more detrimental to the therapeutic relationship. So we definitely want to avoid that at all costs. Um, One of the things that I use a lot from Bowen is I statements. I statements are really, really beneficial when we're trying to teach families how to communicate. Um, and let's see. Okay, I'll just use an example that I use for my families a lot. So I statements, it starts with, I feel blank when you blank. I need you to blank. So this is how we teach people to communicate. So when we're talking about feeling, it has to be an identified internal feeling. Um, I'm going to take the example of uh, a spouse feeling, or a spouse being upset that, or a partner being upset that the other partner did not follow through with, let's say, cleaning the kitchen, um, as they said that they would. And this is a long-term problem. This happens all the time. One, spouse A is very upset about that, or I mean, partner A is very upset about that. Partner B doesn't really understand what the big deal is. And here we go. So, partner A would be educated in the use of I statements so that partner B can really understand why they are so upset about this. So in this situation, it would be something to the effect of, um, I feel ignored and undervalued when you don't follow through with your agreements to me. Um, I need you to either follow through with your agreements or don't make the agreement. And that's it. That's I statements. Um, and it because it puts everything into the perspective of the person who is saying it. It's not you make me mad. It's this is how I feel when this happens. And so this is what I need from you. Now there's some longer forms of that 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 people use, but that's kind of the gist of it. That's the main one, and that's the one that I try to teach people how to use. All right. So here's our 8 interlocking concepts. Um, they are all tied together. They do not stand alone. Um, and these are these are Bowen's basis for the chronic level of anxiety that we all experience. So here's how they go. Differentiation of self. Um, but then that's kind of what it sounds. How do we identify ourselves as different from our family? Um, triangles. Now, triangles are the functional and dysfunctional um, patterns of family relationships, where I got to think of an example. Hold on. Okay, got one. So, in a healthy family, triangles are actually not a bad thing. Um, this is what we have to remember, but they can be. So, a lot of times, what happens in families is let's thinking about mom and dad, okay, or parents. Um, they tend to become what is known as a dyad. So, that is a two-person dynamic uh, force. They can quite frequently be opposing, and but they can also be on the same side. The problem, though, is that when there is that type of dynamic, then there's no balance. So a triangle of family members actually creates that balance where it's not one against the other. Um, it's usually, you know, two people that are focused on each other, and then a third one comes in to balance that. Um, Now, the way that that can be kind of a negative thing is through triangulation, which is where we have two members of the triangle that actually like target the third. Kind of a different thing. Um, now the nuclear family emotional system is the way that a family handles their differentiation slash fusion. So basically, what we're saying here is when two people join in a partnership, um, the nuclear family emotional system is what both of those two people, if they have not been able to differentiate themselves from family with that differentiation of self, then when they come together, they are going to end up fusing together because they don't have that sense of self, that that individualism. And what they're going to do is they're going to bring with them their own family's way of handling emotional issues. This usually leads to quite a level of dysfunction. The family projection process um, um, is a way or it's a process actually, because it's in the title. It's a process by which a parent will project their undifferentiated self onto the most vulnerable of their children. And that ends up producing another undifferentiated self of the child. Um, Usually, this is going to be a child who is either physically or emotionally vulnerable, or lacking in development. Um, Emotional cutoff is a mm, emotional cutoff is a fairly, I don't want to say underdeveloped, but it is emotional response, um, because it's a way for someone, a child in the family, maybe as they're getting older, that has uh, not been so much the target of that projection process and fusion, um, that they emotionally distance themselves from the family in order, excuse me, in order to relieve themselves from the emotional conflict that originates with the family. The only problem is that it doesn't really solve anything. Um, it only kind of it almost kind of creates like a little bit of a Pandora's box type of situation, emotionally speaking, with the child that engages in that emotional cutoff. The multi-generational transmission process, that is where we see some pretty significant dysfunction in a family structure, um, and it's based on selection of a partner that has a similar differentiation level, usually not all that great. Um, and then we're going to see a pretty decent amount of the family projection process. So those things two tied together is where we start to see this multi-generational, where uh, what happened in the previous generation is going to happen in the next generation, and it's because of those things. Sibling position, I'm not going to go into all of that. There's a lot of stuff with sibling position, but we can kind of I always think about, like, we've got firstborn, middle, youngest, and there are some pretty stereotypical characteristics of each of those placements. Um, I'll let you kind of read that on your own. So do definitely, like, make sure that you look into that. In the book itself, it's not like a huge section, but I would suggest, like, if you really want to understand it, like, getting online and really looking more into that, um, just to kind of go over some stereotypes there. When we're talking about sibling position, it also plays to family roles. So an oldest child is going to be expected to play the role of a secondary parent. They are typically high achievers. They typically are more independent, um, take on a well, kind of already touched on it, but that reluctant caregiver role. Um, they're protective, things like that. Middle child tends to be a little more rebellious. They uh, there's the idea that they feel a lack of individuality because they're there in the middle. Um, uh, they feel ignored. Like I said, they're rebellious. They tend to act out more. Um, but they also tend to be more entertaining. They are um, more outgoing in personality, things like that. And then the baby of the family, the youngest, um, of course, is usually spoiled. Um, that always goes with that. They're usually spoiled. They uh, tend to have a more egocentric um, approach in life. Um, they usually leave the home later than the older children. So there's a lot to go into that. So definitely look at that. And then finally, societal regression. Um, this is basically saying that under intense stress or pressure, that the levels of differentiation that can be attained won't be attained, or people will regress, or society, family will regress to previous undifferentiated uh, levels in order to regain a level of functioning that alleviates the stress and anxiety. These are pretty much, they're based in a combination of these types of therapy, or these types of philosophies. So we've got phenomenological, humanistic, emotionally focused therapies, um, and the focus within these therapies is on the patient's freedom of choice. We're not using any previously defined, or uh, I'll use the term cookie cutter interventions. We're actually designing um, and crafting the interventions that are going to best meet that patient's needs. Um, but what we're also doing is we are very much so focusing on the patient's needs to maintain a self-sense, to encourage them uh, to develop um, the ability to make choices for themselves that are going to lead to bettering their lives. When we talk about these and we're talking about disorders and dysfunction, that is because of um, some sort of block that is preventing the patient from actually uh, leading or going down any path of self-actualization.
Now, symbolic experiential family therapy is a little bit different. This one really seeks to normalize human behavior and remove the pathology or the psychopathology behind human behavior. Um, Essentially, what we're saying is that um, human behavior is based on the way that we experience our world and how we interpret our world. Um, and so, in reality, there really is no pathology behind it. It's just whether it is functional or not. Um, Now, this one was actually pioneered kind of close to home, actually, it right here, Oak Ridge, Tennessee, back in 1941 by Carl Whitaker. So we've got our little therapy claim to fame out here in East Tennessee. So let's look a little bit more in depth at this one. So with this one, we're actually going to include several generations of the family to look at and change some of those frequently pretty rigid ways of interacting that have just repeated, you know, through the family that are actually kind of causing some problems. We want to change those into more flexible, more spontaneous, more adaptable ways of functioning. Um, Within this one, the therapist is going to draw on their own personal experiences, um, own ideas, things like that. Um, we're not going to plan out what's going to happen. We're not going to have a therapy itinerary. We are really just going to go with whatever presents itself, whatever issue the family brings up that day, whatever the theme has been. And the therapist is really just going to use a lot of their own creativity in trying to help the family see things from a different perspective. Again, normalizing, the behavior that's being seen, um, and uh, again, just trying to get the family to be a little bit more creative and adaptable. Um, and then lastly, there just that use of co-therapy teams. Um, so there's not going to be just one therapist, and that's because we're including so many generations.
Human validation. Um, I mean, basically, what we're doing here is we are providing the safe the safe space for people to experience um, the validation that they might not have received, and making sure that families learn how to communicate in such a way that uh, validation occurs naturally. Um, and we have to teach them how to not become defensive, because that's very difficult for a lot of folks. Um, there's a lot of emphasis on our triads there, um, and how communication occurs between those. So we've got our 8 aspects of the self, and this is basically how we understand ourselves. So we've got our physical self, our intellectual self, emotional self, sensual self, interactional self, contextual, nutritional, and spiritual. And we want to make sure that people understand themselves and others through those aspects.
Now, this is just a chart that goes along with that human validation process where we're going to be looking at dysfunctional patterns of communication. And we've got here the category. So this would be just the descriptor, the name of the specific form of communication. Um, and then you can kind of read through the rest of that. Definitely make sure that you can identify these.
So when we're talking about the structural model, what we're saying is that dysfunction occurs when the actual structure is dysfunctional. Um, we're looking at the family, the interaction patterns, um, and we're going to have to actually change the organization or the structure of the family in order for any type of improvement to actually happen. Because of this, therapist takes a very directive leadership role. We're not just necessarily making suggestions or leading someone into a healthy line of thought. We're actually saying, this is what I see. Do you agree or no? And this is what needs to change. Agree or no? Now, here's what we need to do to get to that point. Here's a bunch of definitions. So alignment is how family members unite or oppose each other. Um, coalition is when we have 2 or more family members that actually align against a third. A stable coalition is one that's fixed and inflexible union that kind of becomes the dominating coalition of the everyday functioning for the family. Detouring coalition is when we've got 2 united family members um, holding a third responsible for the difficulties. Um, triangulation is when we've got 2 family members that are, at odds in an argument, having difficulties, and they involve the third to try to manipulate that third one to try to take one side or the other. Um, triangulation is never a good situation to be in. A lot of times when we're doing family therapy, we will have couples that will try to triangulate with a therapist. Um, it's never going to work out. Don't get yourself caught up in those.
So we are going to look at the concepts of wholeness, hierarchy, and subsystems here in just a minute. The rest of these, just for the sake of time and the fact that there are a lot of these, this would take me quite a bit to get through this. I'm going to direct you guys back to your text to look at these the descriptions of these individual concepts. But just and you don't have to memorize each one of these. That's not an expectation, but definitely, you know, have an idea of what each of these are. One of the ones that I will point out that I probably use out of this model probably every single time that I talk to a patient is the idea of reframing. Um, that is such a fantastic concept in just helping patients to see a problem, a person, a behavior, just from a different perspective. Um, it can really bring a lot of insight, also, some hope if that has been lost. But do definitely go into your book and look at those.
So within our structure, that's defined as, and this is our core concepts here, structure is defined as the organized pattern in which families interact. It's not deterministic or prescriptive, it's only a descriptive. So when we're talking about the structure, it's kind of like when we talk about the structure of any type of organization. It's just, we're just describing this hierarchical structure. Our subsystems are kind of like our organizational departments. We can have uh, age related within the family, like generational. We can have gender. We can have our siblings. We can have certain interests that kind of group our family members together. Um, we can have it be spouses and parents. I mean, spouses and parents, um, spouses and siblings, or spouses and children. We can have parents and step parents. All of those become subsystems. And then our boundaries. If our boundaries are too weak, then they become our family members become enmeshed, and that becomes extremely problematic. Now, if our boundaries are too rigid, then we can have that disengagement happening. Um, if we have boundaries that are reciprocal, then basically we're going to have one side is too weak, one side too rigid. So we're going to have enmeshment is going to be demanded from one side, while disengagement has to happen from the other.
Now let's look at the underlying assumptions of the structural model. So, structural model itself and these assumptions uh, are kind of housed or based in that existential humanistic tradition. So it really is looking at the individual experience. Um, so let's kind of look at some of these because these are pretty important. And honestly, I think some of them should be applied to a lot of different situations. So when we're talking about families, also people, um, we are practicing under the assumption that families and people desire homeostasis, that each member of the family wants their family system to stabilize, and that they are um, aware and willing to contribute to the balance of that system. Um, we also are accepting the assumption that families and people are perfectly capable and competent to solve their own problems. So we are not taking away from their autonomy to make their own choices. We are not saying that they don't have the skills or the ability to do it. We are there to help guide them through it. Now, with the concept of power and hierarchy, this does become a very important underlying assumption with this one. Um, we have to understand within a family unit that there typically is one person that holds the most power and makes the final decisions. That is also the person that ultimately takes responsibility for the functionality of the family. Um, This becomes problematic when there is a shift in that. Now, most of the time, parents are going to be that solid unit, and so they are going to be the one person. But of course, we know that there are some families that, we know who makes the call. um, but the whole point though is that the children should not have the power. When the children have the power, it is going to lead to dysfunction. You've got your example there, and really, this is not just necessarily maintaining the hierarchy, but it is maintaining the power within that hierarchy. Um, because children look to the adults to lead, guide, um, create the boundaries, all of those things. And uh, if the ones in charge, if the caretakers, if the parents, if the adults are not doing that, then the children don't function well. Now, going a little bit further in looking at that power and hierarchy concept, um, we have to look more into um, the dynamics of the spousal subsystem. So this is, you know, the parents kind of forming that what I like to refer to as the unified front. Um, they have to develop the patterns of support, compromise, having boundaries that um, recognize that the parents are also people that have their own needs, that they are not simply there to cater to or care for children or other people, that we have, um, well, that their relationship as the top tier within the family is recognized and respected. Now, that doesn't mean that our other subsystems get disrespected, obviously. But we just have to make sure that, well, all of this kind of goes back to making sure that the kids don't run the family. Um, and I've kind of already talked about this one as to what ends up happening in dysfunctional families. This is when the kids have control. And part of that also includes when the parents do not have a healthy subsystem, um, and they end up giving the child more attention than they give each other. They have undermined they have undermined that parental unified front. They have undermined that that spousal parental subsystem. Their relationship as a couple has been undermined with that as well. And children sense that and they will act out. So, how are we going to identify the concepts of the structural model within families that have come in for therapy? So, one of the ways is that we're going to be able to identify that there is a lot of rigidity within our transactional, interactional patterns and boundaries that just have all but halted um, the ability to adapt. Um, the manifestations, essentially, the problems that are happening in the family, is because there is a kind of disintegration or deterioration of the structural system within the family. Um, the uh, the appropriate power or balance of power is not where it's supposed to be. Um, and so that's what we need to kind of help them do is kind of get that structure back, get that hierarchy and distribution of power. Um, back to uh, more appropriate and functional levels for that family.
What we're doing is we're going to basically kind of challenge what the family believes is the actual problem, because if we're noticing that there are structural issues going on, and we're going to take a structural model approach, then um, we're going to identify that, oh, okay, so we think that the child is the problem. Let's give the example of family comes in with a child that's acting out. um, Parents come in and they say, yeah, our child is the issue. Where he won't listen, he won't do anything he's told, he's getting in trouble, he's very disrespectful, blah 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 blah. Very common statements. So what we do as a structural therapist is we're going to challenge that and say, well, how do we think that children function? Um, what is your role as a parent? Um, have you taught your child how to follow first requests? Have you taught your child how to respect consequences and respect authority? What are your boundaries like? What are your subsystems? Do we have one parent that sides with the child in undermining the other parent? Um, this is what we're doing. Um, we're actually going to point these things out, and then we're going to let them figure out how they want their family to function. Um, and then we're going to help them get to that goal. So, as I've already talked about, our therapeutic goals for a structural model is that we're actually trying to change the structure of the family. The way that we go about that is by helping the family reform the structure that they have, um, so that it better fits their family. And then that will prompt them to be able to change the structure itself. We've got to work on boundaries. We've got to focus on this hierarchy. Um, what structural family therapy identifies as its uh, differentiating and distinguishing quality is that it puts an emphasis on modifying family structure in the immediate context of a therapy setting. So we're not just educating, we're actually doing this in the moment. Now for our strategic models. Our strategic models are um, most, sorry, I'm readjusting myself, uh, are most characteristic of what we do see in family therapy today. Um, it's very straightforward. We're saying, here's a presenting problem. Um, here's a suggestion for how I feel like, as a therapist, how I feel like this would best fit your family. Um, there's a lot of influences, but its primary is in communication theories. So, for the most part, we're focusing on verbal and nonverbal exchanges. Um, we're talking about what is occurring rather than why, and looking at the ways that families interact, um, and trying to help them to uh, define those interactions and then redefine their actual relationships through those interactions or through changing those interactions also. There's 4 different perspectives, and we're going to go through these. Um, we're going to focus on efficiency. We're change oriented. We're going to make this brief. We're going to get right to the bottom of it, and we're going to talk about the technicalities of our interactions that are causing our problems. Um, we're not looking at families as pathological in any sort of way. We're talking about this is just how we're communicating, and so we need to change how we're communicating. So first, we've got our MRI interactional family therapy. Within this one, we're really looking at semantics, syntax, and pragmatics of communication and how a breakdown in communication patterns or poor communication just in general can actually lead to the family dysfunctions. And we've also got different changes that occur. So we've got our first order changes. These are superficial behavioral changes. Within the system, the structure doesn't change itself. Um, these are usually short-lived, but it is a good indication that the family really wants to improve. Um, these can be things like very simple superficial changes in vocabulary, um, or acknowledging a need for an agreement on chores, things like that. Second order change um, is going to actually involve a fundamental revisioning of the system structure and function. So this is where we're actually going to change these patterns. So for example, something that we might do here is we're actually getting a parent to understand that um, your child is throwing a fit and becoming aggressive because you are inconsistent in telling them or how you handle turning off their video game. One day it may be you give them a warning and then they get to play for another 2 hours because you forgot that you told them to get off. And then the next day you just walk in without warning and turn off the video game. So we're actually trying to get people to understand that we've got to change how we're interacting. Paradoxical communication. What this is saying is that there's communication is not simple. We communicate both verbally and non-verbally simultaneously. Um, a paradoxical injunction is a double-blind message. So what we're saying is that, so what we're saying here, it always takes me back to uh, the stereotypical type of statement of don't talk unless I tell you to talk, and then, you know, a few sentences later, why aren't you acknowledging that I'm talking to you? And it's like, well, I tried and you told me not to say anything. Why are you talking back? You're talking back right now. Only talk when I'm asking you something. So it's this kind of message that is conveying that, like, for example, the message must be obeyed, but must be disobeyed in order to be obeyed. So if I'm saying, answer me or acknowledge that I'm speaking to you by saying, okay, we'll say that, but I've already told you not to talk unless I've directly told you to speak. So it's this back and forth that um, we can't make any we can't come to an understanding about how we're supposed to navigate this. Here's our axioms of interpersonal communication. All behavior is communication at some level. We have to understand that. If someone, we're talking about all of those nonverbal cues as well, and getting families to understand um, the importance of paying attention to those nonverbal cues, especially when we're teaching parents how to uh, interact with children and teach, appropriate emotional expression and that sort of thing, um, and actually verbalizing wants and needs. Um, Paying attention to all behavior as a form of communication is a very important thing to pass on to our parents when we're teaching this or when we're working from this theory. Communication may occur simultaneously at many levels. Every communication has content and a relationship aspect. Relationships are defined by command messages. Relationships may be described as symmetrical or complementary. Symmetrical relationships risk becoming competitive. Complementary communication, sorry, I had to figure out that grammar. Complementary communication inevitably involves one person who assumes a superior position and another one inferior. Um, each person punctuates a sequence of events in which they are engaged in different ways. Problems develop and are maintained within the context of redundant interactive patterns and recursive feedback loops. We're going to go over some of those things. But if you want to know more details of some of those, I guess, new wording, such as redundant interactive patterns, if you want to really understand that, you can definitely make sure to read about that in your book. We've got the therapeutic double blind. So what we're doing here is we're actually forcing a family to examine their communication patterns um, by uh, forcing family members or a person or a couple into what we call a no-lose situation. So, for example, if we've got a family that is struggling with the depressive symptoms of another family member, um, what we will do is we will actually advise the depressed patient or the depressed family member, don't be in such a hurry to give that up. Let's talk about how all of this, affects the family. Let's talk. What does this mean to everybody? You know, if we have someone who's depressed, what's where does this become the dysfunction? Um, we can do prescribing the symptom. This one's kind of fun. I've done this a couple of times, where you actually will exaggerate whatever the symptom is. The example given here is that if we have a family that constantly bickers, everybody's always arguing, then the uh, the homework, um, the prescription, so to speak, is that they have, you know, every single day after dinner, that family has to argue about something for 15 minutes, no matter what, no matter what. Because what you're doing here is when you're calling attention to it, it it becomes more recognizable as dysfunctional. Um, because then what the family does is they're like, well, we didn't have anything to argue about. Like, we didn't need to. Or they might utilize that time. They might save up all day long and then be like, wait till our 15 minutes after dinner, and actually have better communication throughout the day, and then using that time as that. Um, then we can do relabeling. Now, this is actually a really good thing, because let's say that we have a situation this is from kind of like a child's perspective. So we have a child that is viewing a parent as overprotective. Um, we're going to flip that. We're going to say they're not overprotective, they're being helpful. We're also going to change uh, negative terminology from parents to children. So one of the terms that we might use is instead of attention seeking, we might say attention needing. Um, Instead of saying stubborn and argumentative, we might say independent, things like that.
Let's briefly look at the strategic models. So, strategic family therapy being the one that we're going to look at here. Um, Strategic family therapy is a little bit different than structural. It's similar but different. So the focus in structural therapy was to examine the roots of whatever the presenting problem was. With strategic family, we're not really trying to figure out what caused the problem. We're just trying to artfully alleviate the presenting problem. Um, Now, some of the ways that we are going to use a lot of the same uh, concepts from structural therapy, identifying triangles, sequences, hierarchies, things like that. But now we're going to also include giving advice, direct suggestions, actually coaching, giving homework, even possibly assignments for family members. Um, this one is extremely goal oriented, like specific goal oriented, um, and focuses on developing and utilizing problem solving skills. Um, yeah, we'll leave it at that. So now we've got Milan systemic model, which is now more commonly referred to or known as systemic family therapy. Um, Within this one, we're kind of shifting away from identifying and focusing on those interactive sequences and patterns. And now we're actually looking at the family's belief systems. Um, so within this one, we're looking at concepts such as counter paradoxes, those double blinds, positive connotations, rituals that families might engage in. When we talk about rituals, talk about like, our holidays, the things that we do. Um, some of the new intervention strategies that are added to this one are we've got hypothesizing, neutrality, and then circular questioning. Um, I really think circular questioning is kind of an interesting intervention um, because it's basically asking each family member, like let's say two siblings are having an issue, right? We're going to ask each family member to define the relationship between the siblings and address kind of the difference that might be kind of leading to uh, what's going on. It's very interesting. Now we can add the post Milan um, model. This is basically just the Milan family therapy with the added questioning interventions. And these are all the different types of questioning that we can use. Again, I'm not going to go through these for the sake of time, um, but definitely go and kind of look at these and just familiarize yourself with them. Throughout the program, we have talked a lot about behavioral and cognitive behavioral models, so I'm not going to go super in depth in reviewing what those are. Um, but we do have some different applications when we apply these to um, family therapy. So obviously, we're going to utilize these when we can identify a specific behavioral problem. Example would be poor communication or maybe a specific behavior that a child is exhibiting. Um, there are two specific types for couples therapy. We've got behavioral couples therapy, which is based in operant conditioning. Um, and then we've got integrative couples therapy. And this is to really kind of help couples strengthen the relationship for the future in that we know that there are going to be differences. We know that the longer someone, that people are together, that those little things, they start to kind of add up and get on our nerves and things like that. Um, so this is focusing on trying to build that tolerance um, of those differences, so that the family and or the couple remains intact. Yeah, and I think the rest of this is the stuff that we've kind of already gone over, specifically in individual therapy.
Now we've got social construction models. We're going to talk about these two together. So we've got solution-focused therapy and collaborative therapy. So within these, we're kind of moving away from that hierarchy of therapist as expert, and just kind of making it more of an equal. Um, there is the accepted assumption that individual realities are invented through our own perspectives and our um, family belief systems and the like, that they are not necessarily discovered. Um, these therapies also incorporate basic characteristics of the social constructionist theories. So egalitarianism, client as expert. We're always going to explore the assumptions about the problem. Um, and then the goal is to help clients or patients explore new meaning. So we're looking at kind of some reframing happening. So we've got solution-focused brief therapy, um, therapeutic conversations, miracle questions. Miracle questions is kind of the magic wand question also. If if a miracle could happen, what would need to what would it need to be to change things? Um, and then we've got solution-oriented brief family therapy. Within this one, some of the things to kind of point out is we're we're trying to get patients and families to understand that change is inevitable, um, that we cannot function um, without change as a family goes through its developmental stages. Um, and so problems are going to come up unless we accept that we have to change. And we only have to change a small amount. Um, that they are, our families are well equipped to make those changes.
Now, these are the techniques that we're going to use for both solution focused and solution oriented. Um, in pre therapy, we are basically going to go ahead and try to get the person to engage in therapy before they've even started. One of those things is to identify that even scheduling an appointment starts that positive change. Um, there's something about that action. In that initial session, this could also be maybe in a consultation or between consultation and first appointment. We're going to ask the question, okay, so since you made the appointment, what have you done? What have you done differently? Because again, just simply setting that appointment can motivate people to go ahead and start doing things that they believe will help. Maybe things that they've tried before, maybe things that they know will help. Um, and so we've already started that therapeutic process, that journey before they've even made it in on that first appointment. Um, we've got a lot of questions with this one. We've got those exception questions, miracle questions, scaling questions. We're already used to scaling questions. We use those quite frequently. Um, but let's talk about the exception question and miracle question. So with the exception questions, this is when we try to get folks to identify a time in their life when whatever problem it is that they're struggling with didn't exist, but maybe should have. Um, and the whole point here is to try to identify what was different. If, let's say, let's just make it something very simple. Let's say if on one exam you did fantastic, even though it was harder material, but then on another exam you didn't do so great, but the material itself was mm, objectively easier, maybe less. Um, Now, what we're going to do is we're going to say, okay, well, what was the difference between these two? If the material was harder, then the expectation would be that you would have made a worse grade, but you didn't. So what was different, right? And that's kind of, like I said, that's a very simplified example, but that's an example of that one. And with the miracle question, it really is basically getting people to identify what would be different if the problem didn't exist. What would need to change for this problem to not exist? But we do that, we ask that question by saying, okay, if miraculously you woke up tomorrow morning and this problem didn't exist, what would have changed? And that's where they are able to identify what their goal or the actual solution might be. Now, this slide here is just kind of going over some specific techniques in how we would want to structure our our therapy sessions if we're going to use solution focused or oriented techniques. Um, so that's what you've got over there in the left hand column. And then on the right hand here, this is just some of the concepts that we would apply with group counseling. So this would be, utilizing this and applying it to a family group. Now, if you notice again, we've got that recurrent theme that we've seen in quite a few of these, that people are competent and able to solve their own problems. We are simply here to help them along the way, to help them see whatever barriers they might be encountering and to find ways over, around, or through those barriers. Um, there is, of course, that maintenance that our patients define what is important in their lives, what their goals are, what they um, what they want.
So when we look at social construct or social construction models, the only one that we're going to look at in this grouping is narrative therapy. So this one is really going to emphasize the quality of the therapeutic relationship, and that the client
is the expert. They are the primary interpreters of their own experiences, not us. We will invite them to use new language to describe and uh, verbalize, even sometimes, maybe they haven't done that before, their own experiences. Um, Within therapy, we are definitely going to try to avoid um, our own predictions or interpretations, and we're definitely going to avoid any pathologizing of the person's experience. That is completely on them to describe and define.
All of these points are important to embrace within this. So we have our narrative metaphor. We live our lives through the stories we construct. Our lives are multi-storied. Um, there is a dominant discourse or story. Um, there are aspects of post-constructionalism and deconstructionalism, um, thick and thin descriptions, self-narratives, cultural narratives. All of these are a basis here. Therapeutic techniques. It's not really a lot of structural to it. It's very philosophical, humanistic, uh, existential, and just the experience, the life experience. We're going to ask a lot of questions, lots and lots of questions. Um, and that helps it helps people to really explore their story, their narrative, to think about things in different ways, to think about things and explore things that maybe they haven't yet. We're going to help in identifying, renaming, um, reframing, uh, whatever the problem is. We're going to help them to separate from their problem. Um, and we're going to explore why or how, or I guess, and how the problem has become such a force in their life. We're going to help them look for exceptions. We're going to help them identify how they have grown, learned, or what they can learn from their story. Um, this is, in a way, I guess, kind of an example might be assisting someone in switching their narrative from being a victim um, to learning about how they can grow from that and how they can become different in that way. Um, so from victim to survivor.
So some of the techniques in narrative therapy that we're going to use can be labeled as therapeutic conversations. One of the ways is in externalizing and then also deconstructing. So basically what we're going to be doing here is we are externalizing the problem. We are separating the person from the identified problem. This helps them to uh, be able to identify times that they've dealt with this problem successfully already. They've already done it because when they're unable to externalize it, they're just there's just going to be a big barrier. They're not going to be able to see that very clearly. Um, what we're also going to do then is once we identify these stories, these narratives that are kind of just problem laden, we're going to externalize, deconstruct, and we have to do that before we can assist in creating these new stories, new narratives for our patients, for their lives. Um, in creating alternative stories, um, the assumption there is that all of us kind of constantly are rewriting the perspective of our own lives. And so what we're doing with this is we are encouraging our patients to do that, to actively do that, because we don't always recognize when we are, but when we can externalize, deconstruct, and then reconstruct alternative stories, that's when we have the opportunity to be a little bit more creative in the stories that we tell ourselves about our own lives and what those stories mean. And then finally, we've got our psychoeducational models. Now, these are ones that as nurses we are very familiar with. Um, I don't really think that I need to go super in depth with this one because, again, as nurses, we are very familiar with these. Um, this is simply teaching. We are teaching skills, we are providing knowledge, uh, whatever a patient or a family may need. Um, when we apply this in family therapy, we do have some medical family therapy models. We've got a biopsychosocial model. We've got the family therapist physician partnerships. Um, and then on the right hand side there those are some specific models for single families and multiple family groups. Um, so there's quite a few, and a lot of these, again, this is stuff that we are very used to doing, which is providing education um, and skill sets. And that is all that I have for you guys today. Um, as always, let me know if you have any questions or need any clarification on any of these topics covered.